Good morning, everyone, and welcome to the simulation session at the Norman Education Research Day. I'm so delighted that you were all able to join us, and I hope it is a very interesting and thought-provoking session. We have 6 presentations. Each will be 5 minutes and 5 minutes for questions. You're welcome to engage in questions in 2 different ways. You can raise your hand and I will call on you to unmute and ask your question, or you can type it in the chat and I will ask it of the speaker. At the 5-minute mark, if you're a speaker, you will hear a chime to let you know that the speaking time is up. I will provide the posters. And maybe I'll ask our first speaker, Maria Rusakis, to present on transfusion medicine, preparing for the worst, use of crisis resource management for massive hemorrhage protocol simulations. Maria.
Thank you. So as Matthew said, my name is Maria Rusakis, and I am a Master of Science candidate in the Health Science Education program. I also work as a medical laboratory technologist. So to begin with, a massive hemorrhage protocol is initiated by the most responsible physician whenever a patient is experiencing significant hemorrhage. Medical laboratory technologists that work within the transfusion medicine laboratory provide life-saving products as well as performing any transfusion testing for these patients. So it is important for these professionals in these crises to have effective interpersonal skills, and these include organization, teamwork, and communication. Adequate training must be provided in order for these professionals to be prepared for these events. For this reason, crisis resource management is an effective framework to be used, and this framework addresses the behavioral and cognitive skills required for resource management during such crises. When developing any simulation scenario, and using a simulation scenario for crisis resource management, it is important to keep in mind the 5 main crisis resource management principles, and these include leadership and followership, communication, teamwork, resource use, and situational awareness. In making a simulation scenario, an example that I have presented in my poster is a clinical vignette of a John Doe presenting to the emergency department with a massive hemorrhage. So during the simulation, various things are needed to be considered. The patient's state would progress, and different modifiers would be included, and these are learner actions that would cause a change in the simulator, as well triggers, which are events that cause a change in the simulator, would also be instituted throughout the simulation. And when creating different simulation scenarios, it is important to have varying degrees of difficulty with different scenarios. I have shown in figure 1, I know it is a little bit difficult to see, but I have created a flowchart that demonstrates 2 different simulation scenarios. The flowchart that veers to the right, it is a more difficult scenario in which a patient has positive antibodies present, and finding compatible blood products and performing transfusion testing is further complicated. For the simulation scenario in the flowchart that veers to the left, it is a much simpler scenario in which a patient does not have antibodies. So the transfusion testing is completed much easier. Prior to conducting any simulation with learners, a dry run would need to be completed with the simulation team. And just prior to the simulation itself with the MLT learners, a pre-brief session would need to occur in order to make sure that the learners are familiar with the institutional massive hemorrhage protocol, as well as the learning objectives for the simulation, and the scenario layout. When assessing learners' skills and behaviors during the simulation, an important assessment tool that can be used is a global rating scale, which I have included in figure 2. And the assessment tool, the global rating scale I created, uses the Crm Principles as learning objectives. Evaluation of learning can also be completed in debriefing sessions, which occur after the simulation, so learners can reflect on their experiences. The PEARLS debriefing framework is recommended, and in this debriefing framework, there are 4 stages of debriefing. The first is reactions, the second is description, the third is analysis, and the fourth is summary. So it is important to debrief good performances in order to learn from successful scenarios and not just focus on what went wrong. In conclusion, a recent study in Ontario highlighted the top recommendations for massive hemorrhage protocols, and these included that healthcare professionals involved with such events should be trained and participate in drills. Since medical laboratory technologists are involved in issuing blood products and performing transfusion testing, they should be trained using simulations for these crises. Crisis resource management is an effective framework for training these professionals. And by practicing these behaviors, clinical testing errors and patient mortality could significantly decrease. Other professionals could easily be incorporated into the simulation, and this would further increase fidelity, interprofessional communication, and interpersonal relationships. Thank you.
Thank you so much, Maria. Certainly a really important topic to conduct simulation around crisis resource management. I'm curious, just to get the conversation started, what prompted you to study this topic?
So as I mentioned, I am a student in the health science education program, and this was for the simulation course taught by Dr. Grierson. So this was, we learned about this concept in the course, and I found it really applied with myself working during these massive hemorrhage protocols. And, you know, it's just such a high crises scenario, and you really have to know and be able to organize and be able to communicate effectively during these crises. So I kind of thought that the framework worked really perfectly for this scenario, and that the topic hasn't really been discussed much because in this field there isn't much simulation training, especially in laboratory workplaces. So I thought it would be a really interesting topic to look into.
It certainly fits the bid as something that's rare, but high resource use with high impact. Great. We open it up to the group for comments, questions, and anything you want to bring forward. Feel free to either raise a hand or enter something into the chat.
So Brittany Pierce asked, you mentioned that simulation scenarios should be implemented. How often do you think these should occur to make a difference in crisis management for MP? So I think that would vary between the healthcare institution. I think a minimum of once a year would be a good standard to go by, especially to refresh those who have not experienced a massive hemorrhage protocol. But I think it does depend on the healthcare institution, because especially with trauma centers, the medical laboratory technologists that work in the transfusion medicine laboratories would experience these much more, and perhaps with greater variety of them. So I think a minimum of yearly with any kind of workplace training, but definitely could be adjusted based on the type of healthcare institution. Yes, I know. I printed it out because I thought someone would ask that. So like I mentioned, it had the 5 CRM principles: leadership and followership, communication, teamwork, resource use, and situational awareness. So under the leadership and followership heading, the objectives would be takes on leadership role confidently, feels empowered to voice concerns to team members. Under communication, it was communicates needs to team members. For example, assistance from other MLTs, requesting type and screen sample from clinical unit. Respectful communication is maintained with all staff. Assigned tasks to team members are communicated effectively using a closed loop system. And a closed loop system is something part of crisis resource management in which the leader says the task to the team members. The team members repeat the task to the learner to make sure that they have the task correctly in their head. And then once the task is completed, they relay this message back to the leader. And that is what is called closing the loop, which is very important to do when you're communicating during crises. And also in the global rating scale, under communication, reports laboratory results in clear and concise manner. Under teamwork, delegates tasks to appropriate staff when needed, does not assume all workload when overwhelmed. Resource use prioritizes time efficiently, uses equipment and reagents appropriately. Situational awareness reassesses workflow based on patient's need, manages conflict appropriately and professionally. And also the final box was analytical procedures, so to make sure that they're actually performing the testing correctly as well.
Wonderful. Well, thanks so much, Maria. A round of virtual applause, and we'll move on to the next presenter here. Thanks again, Maria. Next, we have Daria Yilmaz presenting on the role of equality, diversity, and inclusivity in standardized patient programs. Daria, you have the floor.
Yes, hello, Dr. Simon. Thank you so much. Hello, everyone. My name is Daria Yilmaz. I have been working as visiting scholar in Center for Simulation-Based Learning at McMaster University. Today, I am going to talk about how standardized patients program should support equality, diversity, and inclusivity in health science education training. Before this start, I want to use the standardized patients as SP, and I want to use equality, diversity, and inclusivity as EDI as well. So SP is a health person who is trained and represents patients, and SP program is responsible for supporting and delivering SP to help in the training and assessment of learners in their education. Integrating EDI in health science education curricula is a frequently institutional goal, but how SP programs should support EDI-based educational approaches in health science education training is less well described. So to understand potential approaches to EDI by SP programs, we performed a narrative review of the available literature. The current literature search for manually using PubMed, Scopus, ScienceDirect, and Google Scholar database, using the terms standardized patients and also simulated patients as well. Standardized patients program, simulation, equality, diversity, inclusivity, and also cultural competence. And then a total 117 articles were identified, investigating the effectiveness and outcomes of included EDI-based approaches in SP program are determined our inclusion criteria. And title or abstract wasn't due to include our key terms and words, were determined our exclusion criteria. And also you can see our plasma follow diagram in the presentation. Finally, 17 articles were included in this study. Then 2 independent reviewers identified each study in scope of key goals and outcomes, then thematically categorized each study. Thematic analyzed resulted in 3 primary themes: improving cultural competence, effective communication with diverse patients, highlighting health inequalities. 9 articles were identified in improving cultural competence, 5 articles were identified effective communication with diverse patients, and also 3 articles were identified in highlighting health inequalities. So most studies reported a positive teaching and learning experience ongoing healthcare students with SP from diverse backgrounds, such as cultural, gender, age, disabilities. But current gap in the literature is not to cover the challenges around the integration of EDI with SP programs. In conclusion, as EDI in SP programs plays a pivotal role in health science cultural education, and also more research are needed to identify best practice to support effectiveness on fostering cultural and communication competence of students. Overall, more research are needed in regard to provide more evidence on the challenges, effectiveness, and outcomes of developing on EDI-based SP programs in health science education. Thank you so much.
Wonderful. Thank you, Daria. I'll invite the audience to ask questions, either by raising your hand or putting it in the chat. Maybe while we'll wait just to start the conversation, Daria, what advice would you have to SP programs who are trying to incorporate EDI ideas into their program?
Yeah, I think maybe SP programs could collaborate different health community, indigenous community, and also the faculty development programs responsible for this, creating the curriculum about the EDI-based approaches. We collaborate them, and I think the SP programs may facilitating and training the SP for diverse background, portrayal the diverse background patients, but we need another faculty development and also community collaborating. So
yeah, in a way, it sounds like it involves the whole community of practice.
Yeah.
Very good. Well, thanks so much, Daria. And a round of virtual applause.
Yeah, thank you.
Excellent. Now, we'll move on to the next presentation by Arden Nazim, Code Blue, an interprofessional simulation-based workshop for junior learners. Arden, welcome.
Hi. So this project is called Code Blue, interprofessional simulation-based workshop for junior learners. And as a background, so we know that simulation-based resuscitation training is an effective intervention to improve interprofessional team function and confidence among practicing physicians and nurses. And simulation lets healthcare providers practice both the hands-on skills, but also interprofessional communication and teamwork in a low-stress, low-stakes environment where patient safety isn't at risk. Because of this, there's also growing interest in developing simulation-based workshops for more junior learners. And so medical students, nursing students, physician assistant students, all before the licensure level. And several models of workshops do exist for junior learners, but these are often uniprofessional, so just for medical students as part of their curriculum, or for nursing students, or also are higher resource requiring a lot of faculty investment and time, or also longitudinal workshops that are run alongside a clinical rotation. So in this study, we describe a novel, single 2-hour interprofessional workshop for undergraduate medical and nursing students, designed with a near-peer facilitation. So our objectives for this study were first and foremost to assess the effects of a novel simulation-based workshop for junior learners. As this was an interprofessional workshop, we wanted to look at the effects on interprofessional role clarification, and then also look at the effects on attitudes towards participating in a code blue in the clinical setting. And then secondly, to characterize barriers that learners perceive to participating in a code blue in the clinical setting in order to identify areas of intervention for simulation-based education. So we recruited participants from medical and nursing students who attended a Code Blue workshop run at the McMaster Center for Simulation-Based Learning. This was a voluntary workshop outside of the formal curriculum that was assigned for IPE credit. The workshop was structured as follows. So we had, first of all, a group introduction just to interprofessional learning and to simulation, and divided students into groups of 4 to 5 in interprofessional groups. And they rotated through 4 stations. So the first station was calling for help, which is who comes to a code blue, when do you call a code blue, and how do you assess an unresponsive patient. Second station was on the mechanics of CPR. Third station on airway management. So this was focusing only on non-invasive airway management. So bag valve, mask, and then oral and nasal airways. Intubation was outside of the scope of this workshop, given the level of training of the learners. And then finally, defibrillation. So again, simplified to shockable and non-shockable rhythms, and how the role that defibrillation plays in a code blue response. While all of this was based off of ACLS materials, the things like medications or more intricate or detailed part of ACLS were also outside of the scope of the workshop. We then had students participate in their small groups in an integrative team-based high fidelity simulation, followed by a facilitator guided debrief. We asked students to rate their pre and post-workshop understanding of interprofessional roles and also of their confidence participating in the code blue response. And then we asked them to describe their perceived barriers to participating in the code blue in short answer form, a free text form, and then we performed a thematic analysis of what barriers emerged. So a total of 10 medical students and 7 nursing students participated. No students had previous ACLS training, and only 1 student actually had previous exposure to a code blue in the clinical setting. For understanding of interprofessional roles in a code team, students' scores on a 5-point scale increased from 2.5 to 4.3. And we similarly had an increase in students' self-rated perceived confidence participating in a code blue response from 1.8 to 4. In addition, students identified having a safe learning environment, the hands-on practice, and the integrative simulation as very valuable parts of the workshop. In terms of barriers to student participation in a code blue, lack of clarity about roles and lack of knowledge and experience did emerge as barriers, with a pretty even split between nursing and medical students. But the most prominent barrier that emerged was actually fear or anxiety around making a mistake in a code blue in the clinical setting. And this was identified as a reason why students would be reluctant or had low confidence about participating in a code blue. For most of these learners, or really all of these learners, this workshop was a first exposure to a code blue scenario, and we see this reflected in the low pre-workshop scores, both of their understanding of interprofessional roles in a code team and also of their perceived confidence. And this increase in self-rated confidence post-workshop may reflect an increase in readiness to actually participate in a code blue as students transition to the clinical setting and move through their rotations. And also fear and anxiety around making a mistake really emerged as a prominent barrier to participating in a code blue response identified by a majority of students. And this is an area where simulation-based workshops may be really well suited to address this, and also an area interesting to explore later on in terms of how this barrier manifests for students and how it can be addressed by simulation-based education. So in conclusion, a short interprofessional simulation-based workshop is effective intervention to improve interprofessional role clarification and also perceived confidence participating in code blue, even among very junior learners early on in their training.
Great, thank you very much, Arden. I noticed a question here in the chat from Monica. Great presentation. What are the next steps to move these students to the zone of proximal development?
So for these students who've completed this workshop, for them really participating in this integrative simulation would be their zone of proximal development for them. The next step would likely be actually participating in these in resuscitation or code blues in the clinical setting or in a workshop as part of their formal curriculum.
Great. Somewhat influenced by Nicole Wood's presentation this morning, I wonder where you think basic science might fit into this workshop.
So that's a good question. I think I think in terms of having the professions participate, or
Right. Yes.
yeah. So there actually have been some workshops described in the literature where they integrated medical lab technicians and other pharmacy, other professions into similar workshops, and they did actually find roles for these students in both understanding the roles that these professions play in a code blue response, even because often that's behind the scenes. So I think it actually would be very feasible to expand it to that and bring those students in. It's been done before, and it did increase readiness to collaborate in professional settings among all of these professions, and also an understanding of roles.
Very interesting. There's also a question by Stephen Slade. Do you think the increased knowledge and confidence will be lasting?
So that's actually something that I think is an important next step to look at here, whether this actually translates over time. So I think repeating the simulation, or alternatively surveying students and seeing if this actually translated to an increased confidence as they transition to the clinical setting would be helpful. I think it likely would last over time. Some similar workshops have found that increase in interprofessional understanding and confidence did persist at a month on self-rated evaluation. I think there's more questions around whether it actually persists in terms of students' actual performance or willingness to participate in a code blue.
Great. Aaron asks a question. Did you notice differences in pre-post confidence level depending on level of training?
So the level of training was fairly uniform, especially for the medical students. Almost all of them were second year medical students, or early in third year without a lot of clinical exposure. So there weren't really many differences to notice there. In terms of the nursing students, the sample size was so small that it's difficult to make a lot of extrapolations about that. But obviously the one more senior nursing student did have higher pre-confidence level in participating in a code blue, and this was a student who had done so before. I think there's a question from Megan as well.
Go for it, Megan.
Oh, just about who facilitated the workshop.
Oh, right. I see it. Sorry, I missed that.
So first year internal medicine, family medicine, and emergency medicine residents actually facilitated the workshop. So it was fairly close in terms of to the students, not having faculty or more senior residents facilitate. And I think actually this may have, having residents who are closer to their level of training may actually have helped with that level of fear around the simulation. And I wonder if that actually was part of creating a safe learning environment for them. Because I certainly agree, having superiors present, especially people who have the capacity to evaluate them, would play into fears both from the hierarchy and a fear of making a mistake in front of someone who has the power to evaluate you or give you negative feedback.
Wonderful. Thanks very much, Arden. A round of virtual applause. And we'll invite the next speaker, Sandra Westcott, who will present on Physicians First, Simulating Medical Emergencies in Psychiatric Settings.
Hi there, my name is Sandra Westcott. I'm a senior psychiatry resident here at McMaster and also a trainee in the clinician educator program. And I'm here today presenting on behalf of a group of medical educators, as Dr. Sibbald introduced, on Physicians First, Simulating Medical Emergencies in Psychiatric Settings. Simulation is widespread in other areas of medical education and remains relatively underutilized in psychiatry. This is actually the first time that we've incorporated simulation into our postgraduate training program, and it's situated within a broader, novel medical psychiatry curriculum that was developed in collaboration with faculty in psychiatry as well as in emergency medicine. For the simulation component in particular, we also partnered with staff from the 3G Child Psychiatry Inpatient Unit, as well as McMaster's Center for Simulation-Based Learning. We developed 2 simulation scenarios, one using a high-fidelity mannequin to simulate a pediatric psychiatry inpatient with a seizure, and another using a standardized patient to simulate someone with unstable vital signs in an emergency psychiatry setting. There are a couple of key considerations that we have to think about in managing medical emergencies in psychiatric settings that distinguish it from how these similar situations might be managed in, say, an emerge or CTU setting. And those need to be accurately reflected in the simulation. So the first thing is thinking about what is really actually the role of a psychiatrist in managing these medical emergencies. What we felt was most important in creating the simulations was that 1, trainees were able to recognize that there was an emergency happening. 2, that they were able to identify what resources are available to them and who to call for help. And 3, to manage the first sort of 5 to 10 minutes of the scenario. The other thing that we had to make sure was accurately represented was some of the environmental considerations on psychiatric inpatient units and emergency settings in particular. So one of the most obvious ones is that everything is behind locked doors, be that a crash cart, medications, even letting help in the door. We also have variable access to supplies in psychiatric settings. So emergency supplies can range from basic PPE and a bag valve mask, all the way up to a more or less complete crash cart, a fully stocked crash cart. But again, it's highly variable between settings, and most sort of fall somewhere in between. And then the third is sort of the role of interprofessional staff. Mental health nurses may or may not have experience in, for example, putting in IVs, particularly in emergent settings. And so in thinking about the role of a physician in ordering something in that setting, we have to also be aware of what are the skills of the staff that we're working with too. So for the simulations, we had 7 PGY1 psychiatry residents participating, as well as 1 RN from the child psychiatry inpatient unit. The sessions were co-facilitated by myself and Kai Pardon, who's an emerge doc. And we ran them at the CSBL, and one of the pictures there just sort of shows the awesome job that the staff there did in setting up the environment to look like a psychiatry setting. We evaluated our sessions using a pre and post survey, looking at perceived comfort managing medical emergencies, doing a bit of a program evaluation in terms of perceived effectiveness, as well as a needs assessment, because this was the first time that we used simulation in our program, and we wanted to explore opportunities for future simulation. We also did a bit of a qualitative analysis around the debriefing, and in particular, the component where we asked participants to reflect on 1 or 2 key learning points that they could take away to future practices, and found that there was 4 sort of key themes that emerged, and 3 of them are actually fairly closely related. So those are calling for help, recognizing the scope of practice, and the resources that are available in psychiatric settings. And those sort of tie back to those initial considerations that we were thinking about and how to manage a medical emergency in psychiatry. The 4th theme is that around a medical expert role, so things like interpreting an ECG or what to give as abortive medications. For the survey results, the mean effectiveness score was 5.88 out of 7, with 7 being extremely effective. And all participants felt that it was either mostly or extremely relevant to their practice. There was a trend towards increased comfort managing medically unstable patients, including both specifically for seizures and also unstable vital signs, but the results were limited by a relatively small sample size. And 100% of participants indicated interest in participating in future simulation-based activities, and also recommended having shared facilitation between an expert in psychiatry and someone with expertise in, say, emergency medicine or another medical subspecialty too, as well as interprofessional staff. We were able to identify a few key areas to explore for future potential simulations, including things like adverse medication reactions, strangulation or hanging, and agitation. In summary, psychiatrists need to be prepared to manage medical comorbidities in psychiatric settings, and simulation might provide an opportunity to safely and effectively enhance these skills. Our pilot project contributes to a small but growing body of literature on the use of simulation in psychiatry, particularly looking at the medical psychiatry interface and some of the unique opportunities that presents for interdisciplinary collaboration. So I'll stop there and happy to take any questions.
Thanks so much, Sandra. I'll invite questions either by chat, or by show of hands. Sandra Montero.
Thank you. Yes, hi. Thank you, sorry. Thank you, Matt. I just had a question generally about sort of gathering the information around the willingness to attend future simulation. I'm getting the sense that this is use of simulation for psychiatry training might be sort of new. And so were you able to leverage any of that interest from the trainees to gather more content for future curriculum development, for improving the sim? Does sort of engagement from the resident, have you found, I guess, engagement from the resident or resident actually impact what they take away from the simulated scenario?
Okay, so I think there's almost two maybe separate questions there. So one is around sort of future sim development, and another is sort of around engagement with the sim. Is that kind of accurate?
Yeah, probably. I should have warned you. It was a two-part question.
Okay. So in terms of future sim development, it is something that we're hoping to expand in the psychiatry postgrad training program here at McMaster anyways. So next year, we're hoping to run at least one, if not two simulations, and also recognizing that the literature supports really having more frequent use of simulations is probably more effective than sort of those one-off experiences. So it is something we're hoping to expand. And that is partially informed by the survey results showing that there was a great degree of interest in that. In terms of speaking about like engagement with the sim sessions, one of the things that we also looked at in terms of thinking about how effective it was for people was what their previous rotation experiences had been. So first-year psychiatry residents rotate through a number of different specialties, including things like internal medicine and emerge. And we didn't see that there was really like any big difference in terms of how effective people perceived it to be depending on what they had already done. The other thing that we looked at in terms of engagement was sort of looking at differences between the high fidelity mannequin and the standardized patient. There was maybe a little bit less, and again, this didn't really reach statistical significance because it wasn't a huge sample size, a little bit less engagement with the mannequins, which I think is not perhaps terribly surprising given that in psychiatry, lots of our interactions depend on that face-to-face contact with other people, but it was still perceived as being effective and relevant. Does that answer your question?
It does, yes. Thank you.
Yeah, thanks very much. I also see a question from Teresa Chan asking about some psychiatry applications that people saw for this type of work. Yeah, so that is something that we've talked about again with our program as well, and looked to some of the literature around, because there are some studies published around using sim in psychiatry. Some of the key things that have come up are things like adverse medication reactions, so things like lithium toxicity, serotonin syndrome, intoxication, intoxidromes is another one. Managing sort of code whites, and then also managing some of the medical emergencies that do come up in psychiatric settings once in a while. So things like ligatures, self-harm events is also something that has been explored previously by other groups and things that we have identified. There seemed to be some interest in anyways on this survey that we did. Great. Valerie asked about opportunities to integrate more frequent part task trainer simulation for nursing for procedural skills, such as IV initiation or use of a defibrillator to achieve and maintain skill proficiency. Yeah, I think that would potentially be quite helpful. It's a bit beyond the scope of what we would do as part of like these simulations. I think what we're focusing on is really what is the role of the interdisciplinary staff that we can work with and train together in sort of that complex management. And there are differences, I think, between mental health nursing and other areas of nursing. So for some people, that doesn't get integrated as much as part of their ongoing clinical education. And certainly there's a conversation here about other applications, including things like code white rehearsal. Yes. Yeah. Psychiatric emergencies. Yeah. Yeah. And those are things that we actually have both at St. Joe's and at McMaster, at least in Hamilton, that we do code white training. And that's in situ, which I think is also a really important experience. Absolutely. Well, thanks so much, Sandra.
Thank you.
A round of virtual applause. And I'll invite the next speaker, Valerie Bloomfield, who will present on mode of delivery, development and implementation of an obstetrical in-situ simulation program.
Hi, everyone. I'm Val Bloomfield. I'm one of the OB-GYN residents at McMaster, and we are excited to share our project with you. So as we've heard this morning, we know that simulation is increasingly valued as a learning tool, and it's particularly helpful in obstetrical practice because it allows for the deliberate practice of high-risk, low-volume events. In-Situ simulation is simulation that's physically integrated into the clinical care environment, and that provides the opportunity to train for uncommon clinical scenarios, assess authentic care teams, identify systems issues that have the potential to compromise patient care. The objective of our study was to develop and implement a comprehensive in-situ simulation program to promote knowledge and skill acquisition amongst our interdisciplinary teams. We plan to evaluate non-technical skills to better understand how our team attitudes and behaviors were impacting our patient care. And through the curriculum, we wanted to identify latent safety threats or system-based threats that could also compromise patient care. In terms of a brief methodology, we completed a needs assessment by gauging interest and learning objectives from our care teams, and that allowed us to clarify a list of key obstetrical emergencies, clinical locations, desired collaborations, and the ideal frequency of simulations. Simulations were run without advanced warning on a monthly basis in different settings, including labor and delivery, antepartum and postpartum wards, as well as ancillary settings such as the diagnostic imaging unit, emergency department, and hospital cafeteria. We used hybrid birthing models and simulated patients to create realistic presentations. The participants participating in the simulation used the equipment available within the clinical setting to provide appropriate care. At the end of each simulation, a group debrief was held, and we really placed emphasis on team performance and identification of latent safety threats. We collected written qualitative and quantitative feedback from participants and used the PETRA tool, which is the Perinatal Emergency Team Response Assessment Scale, to assess crisis management of the simulation participants. This is essentially a validated scoring system that incorporates psychometric and behavior markers to objectively evaluate team dynamics in 6 key domains that we'll touch on in a few minutes. During each simulation, organizers and participants identified and documented latent safety threats. Qualitative data was reviewed and recurring themes were identified, and then our quantitative feedback and PETRA scores were analyzed using descriptive statistics. In terms of results, we ran 28 simulations over a 14-month period at 2 academic centers here in Hamilton. Simulations included obstetrical emergencies such as cord prolapses, postpartum hemorrhage, unresponsive patient, and many more. We were able to include 161 participants from fields like obstetrics, neonatology, emergency medicine, and anesthesia, and we captured many clinical roles such as nurses, physicians, medical learners, unit clerks, and allied health professionals. Participants indicated that the simulations were well organized and they rated their experience favorably. Specifically, they appreciated the team environment, the spontaneity and unannounced timing of the simulations, clinically relevant cases, safe learning environment, and the use of realistic equipment. Feedback for curriculum improvements suggested inclusion of more allied health team members and creation of a simulation kit that we could reuse and recycle to reduce waste through our program. Participant feedback identified 3 key learning themes. So team communication, such as closed loop communication and the use of direct and specific language, was highlighted from a number of participants. Participants also noted an improvement in content knowledge, or the knowledge required to respond to a specific obstetrical presentation. And finally, feedback suggested improved procedural knowledge, or what we're describing as the ability to function effectively within a clinical setting. So for example, participants noted improved knowledge in equipment use, how to activate team members, how to transfer care from one area of the hospital to another. Interdisciplinary teamwork was assessed using the PETRA framework. Teams demonstrated an advanced level of shared mental model, followership, and positive attitudes. An intermediate performance was noted for communication, situational awareness, and leadership. On our poster here, we have latent safety threats, which were identified in 5 key domains. So equipment, medication, personnel, resource, technical, and other. And we can sort of go through the specific examples if people have questions during the question and answer period. In summary, we present the development and implementation of a successful in-situ simulation program in 2 busy academic centers. Through our program, we were able to engage an interdisciplinary team who viewed their involvement favorably. We highlight several learning points relating to team communication, collaboration, and the provision of quality healthcare. Our lessons learned serve as valuable information to identify existing systems limitations and inform future policy and procedural change. Further efforts are required to translate this into educational efforts and effective policies. I'll pause there, and I'm happy to take any questions from the group.
Well, thanks so much, Valerie, for sharing your work. Maybe to get the conversation started, I wonder if you might be able to share some advice you would have for other groups who are interested in setting up similar types of in-situ programs.
I think it's a bit daunting to set up in-situ simulation, and particularly unannounced in-situ simulation. When we looked at the literature, other groups have tried to create such comprehensive programs, and they've had a high cancellation rate. So because of clinical acuity or staff shortages, simulations are often canceled at the last minute. And what we found is we were able to achieve a simulation every month at each center by really engaging the team in our needs assessment to find out what their specific learning objectives were, and then by involving them in the debrief. So they found that when they were actually part of the debrief and they were able to provide their feedback, they were able to see the changes to policies and procedures that we were making, and were therefore more engaged in the process and willing to participate.
Wonderful. It reminds me a lot of Michaela Kolb's work on creating psychological safety to allow this important work. I noticed a question here from Lonica. What is the transferability to community settings?
It's a really great question, especially when she notes that the frequency of these events is low. I think that's what makes in-situ simulation perfect for obstetrics, because certainly the frequency of a cord prolapse is uncommon, particularly in centers that don't have as much volume, and that's specifically why we need to train for them. So performing an in-situ simulation will not only allow teams to maintain their clinical skills, but also to identify any latent safety threats or those system-based threats that may interfere with patient care when required. So I think collaborating with different teams within your hospital to develop a robust simulation program on a larger scale really allows for a simulation program to be implemented in individual departments like obstetrics.
Wonderful. And Megan had a follow-up question about how to address psychological safety in this kind of unannounced nature of SIM. And did you find this was a factor?
So certainly in the early days, I think people were a bit more timid and more hesitant to become involved in the simulation. But over time, the team members recognized that our focus was not individual performance at all. It was really about looking at how the team functioned within their routine daily clinical settings, and really focusing on identifying the latent safety threats within the care setting. Over time, team members have commented that they feel much less intimidated by participating, and as team members have become more comfortable, we have much more eager participants when simulations roll out on labor and delivery.
Excellent. Sandra was curious about the measures of team response, particularly growth in shared mental models. I suppose this is a shared stressful experience.
Yes. So in terms of the Petra tool, when we looked at the shared mental model components, the criteria that it measured was a shared understanding of the emergent situation, team working towards common goals, and striving for the safety of both the mother and fetus. And so within that, we were able to target these in the overall evaluation of the team, but also in the debrief to allow participants to open up about those ideas.
Wonderful. And a last question here from Lonica. Any tips on how to extend in-situ sim in the COVID era, where we're reducing number of members in a closed environment? Certainly a true challenge.
So we've actually, because we've had such an established in-situ simulation curriculum, we have rolled out in-situ sim for COVID patients. So we have used it to really inform our policy in caring for pregnant women who are coming in with COVID symptoms. We have used appropriate PPE when we're bringing all of our team members into a room. It has allowed us to practice the use of appropriate PPE to keep both our patients and staff safe. And certainly the feedback has been that even though we're having to make little adjustments to make sure that we're abiding by social distancing or using the appropriate PPE, the use of in-situ simulation has certainly contributed to a safe work environment during COVID.
It's certainly interesting. I've seen work that came after SARS, which actually highlighted in-situ simulation as one of the largest effects at reducing healthcare spread to help manage viral containment. So that's great. Thanks so much, Valerie, and a round of virtual applause. And we'll move on to our next presentation by Shamira Nataraj, who will be presenting on talking the talk in junior interprofessional education. Is healthcare terminology a barrier or a facilitator? Shamira.
Thank you. Hi, so my name is Shamara. I just graduated this past month from the Bachelor of Health Sciences program at McMaster. And I'm going to start by just mentioning a few healthcare terms that you might recognize. Cardex, exploratory laparotomy, asthma exacerbation, pleuritic pain. During our monthly interprofessional education simulation workshops that we hold at the Center for Simulation-Based Learning, these are just some of the terminologies that our students found challenging. And in fact, when constructing interprofessional education or IPE materials for junior learners, many different challenges arise. One challenge that is very frequently identified in the literature is the use of professional jargons or complex healthcare terms in IPE materials. And there's been an ongoing debate surrounding whether or not these complex terms are appropriate for IPE, how they can be introduced properly, or whether they should just be avoided altogether. And upon examining these studies that discuss jargon and healthcare terminology as a barrier to IPE, our research team realized that healthcare terminology could really be divided into two categories. There's first inclusive language that is shared amongst all health professions, and then exclusive terminology that is unique to specific professions and may not be used by the others. And through our study, we wanted to see if junior learners, particularly undergraduate medical, nursing, and physician assistant students, perceive an actual difference between inclusive and exclusive terminology in the way that they categorize specific healthcare terms. And we also wanted to explore their attitudes and perceptions towards the use of complex terminology in their early IPE experiences. And so we set out to answer these two questions through a two-part study. First, we had undergraduate nursing, medicine, and physician assistant students analyze 14 written cases from IPE courseware. Students read through the cases and were asked to identify words they deemed inclusive or exclusive. So as they read through the cases, they would highlight words they thought were inclusive and underline terms they thought were exclusive. And in part 2 of our study, we recruited students participating in IPE simulation case-based workshops at the CSBL that I mentioned previously. These workshops covered a variety of topics such as transitions to workplace learning and handover of care. These students participated in focus group discussions following the workshop about their experiences handling the complex terminology they were faced with both during the workshop as well as in their actual prior clinical experiences. And so if you turn your attention to the right panel of the poster, you'll see the words most commonly categorized as inclusive in blue and exclusive in green. And you can appreciate that the larger the word is, the more frequently it was categorized by participants as inclusive or exclusive. However, it's important to note that overall we found very little agreement in the categorization of words. And out of the 290 total healthcare terms that the students identified, only 46 terms were categorized as inclusive and only 7 as exclusive by more than 50% of participants. And so from this, the data really suggests that while the concepts of inclusive and exclusive terminology might exist, categorization of healthcare language is not consistent, at least among early learners. We hypothesized that this could be due to individual differences in depth and length of prior clinical exposure, or even systematic differences in curriculum across training programs, although we haven't had the opportunity to really explore that in greater detail yet. The focus group discussions were able to really shed light on our survey data, and what we found is that 4 key themes really emerged. First, we found that abbreviations and acronyms were very commonly identified by students as a key barrier to effective communication, not just amongst one student's profession, but interprofessionally, as students noticed that different professions use acronyms in different contexts and different frequencies as well. The second theme that we noticed was really interesting, and it has to do with those concepts of inclusive and exclusive terminology. We found that when students were faced with a term that they were unfamiliar with, they didn't know whether to attribute that to simply being early in their training and just not yet having encountered that word yet, or whether that word was exclusive and maybe not a part of their profession's vocabulary. They just could not know what to attribute it to. And the workshop and the focus group actually gave them opportunities to discuss with their peers, both within their profession and outside of it, and figure this out for themselves. The third theme that emerged was the idea of simulation as a safe space to learn complex terminology. And students pointed to particular characteristics that our workshop had that enabled this, such as having no evaluator present, having facilitators who encouraged and prompted students to ask questions and ask for help, and most notably, the ability to make mistakes in a low-stakes environment in the absence of patient care responsibilities. And fourthly, we found that students really valued encountering complex terminology, both early on in their training and in the interprofessional setting. And so they valued it as a desirable difficulty. They did acknowledge that there was an additional degree of cognitive effort required to learn these complex terms early in their training, while balancing the other demands of the workshop and wanting to develop those interprofessional skills, but they felt that it was certainly beneficial. They did appreciate the scenarios being very realistic and true to what they would experience in the clinical setting, even if it was a little bit above and beyond what they were even learning in their current respective training programs. And so overall, what we concluded from this is what is sort of written in the middle of my poster, and that is that complex healthcare terminology is a desired and valued learning objective in early simulation IPE. And what we hope you really take away from this is that for educators, we suggest focusing less on whether or not to include complex terminology in IPE materials, and even to focus less on whether or not that terminology is inclusive or exclusive, but to focus more on creating a safe environment that is conducive to learning this complex terminology, as well as facilitating discussion of these concepts. Thank you.
Thank you so much, Shamara. I'll open it up to the group for thoughts and comments. Lonica has commented, as educators, we often expect our early learners to just know the medical jargon and do not pause to ask. So certainly this work is interesting in focusing on asking about the terminology we use. I don't know if you want to comment about that, Shamira.
Yeah, that comment definitely rings true to what I've seen through this study. And this came up many times in our focus groups. Actually, students would reflect on how they encountered and how they dealt with terminology that they didn't recognize as maybe first-year medical students or first-year nursing students in the hospital and in the clinic. And they found that it was often difficult to ask. They felt sometimes it would be a power imbalance that would prevent them from being able to step up and ask, or just not enough time when they're not in the simulation setting, when they're in the real life setting. And so they really appreciated this opportunity where facilitators would take time specifically to help students work through this terminology that they didn't understand. And it almost became like a learning objective within our IPE workshop as something, as learning complex terminology as part of it.
Excellent. And Sandra Montero had a comment. Sandra.
Thank you, Matt. Thank you, Shamara, for sharing that very interesting work. You reminded me of a rather old study now. It's over 15, it's probably almost 20 years old, actually, where they found a relationship between how critical medical students evaluated certain healthcare conditions based on how it was labeled. So this kind of adds to that conversation. Potentially this sort of search for meaning when faculty are throwing around words that aren't easily understood might, in the medical students' minds, sort of exacerbate, the significance of it. So in this 20-year-old study, what they found was that when a patient's condition was described using very complex medical terms, the students also rated those conditions as more severe compared to when they were described using common everyday language that someone like myself, a non-MD, would even understand. And so something else for faculty to maybe be aware of, that they might be creating this hierarchy that's not only limiting students' learning, but changing how they interact with patients.
That's really interesting. Thank you.
And Leslie Martin made a comment that as a resident, she looked back on her medical student notes with tabs full of terms, often spelled incorrectly, that she'd look up after the fact. So I think this is something that many in the health professions can relate to in their training. Excellent. Well, thanks very much, Shamira. A round of virtual applause to Shamira and to all of our presenters. I think it's been a very interesting exploration through some different simulation work with a variety of different methodologies and a variety of different contexts. So thank you all for sharing. I hope this is a professionally rewarding day for all those who are attending, opening eyes to new ideas and drawing some links to some co-attendees. So thanks so much for attending. I hope you had a good time. And the presenters, if you could hang around in the room just in case there's some lingering questions, that'd be great. Bye for now.